So today we're going to demonstrate the knee adjustment promoted by Clinic Masters, and it's based on the principle that the tibia bone down here goes lateral, okay? So when it twists lateral like this, we often see in an x-ray that the patella has gone outside. Like we see that all the time. We look at the x-ray and go, oh, that patella is lateral, right? So when this is twisted out of place, you will see that patella go lateral. And so we have a willing volunteer here. So what we will do is we will first touch the patella on the patient, go down to the center of the patella tendon, put our thumb here on the center of the patella tendon, then find the tibial tuberosity. Those should match up. If they don't match up like this, then you know this is out of place and it needs adjusted back to center. Okay, super easy principle. You can pause it for a second. So I come down the patella here, and when I get to the end of it, put my thumb right on the center of the patella tendon, and then I'm going to try to find the tibial tuberosity, and it's right there. So you can see that those are not lined up, right? There's actually a seam literally right down the middle, and she's over here, right? So it's like, it should be like this, and we're kind of like this, right? So that tibia, it has gone lateral. So if I check the other one, usually I come around to the other side of the patient, but I'll just do it this way. Find that patella, go down to the center of it. I actually think that this one's worse, and you can kind of see it. You can just kind of see this is out over here. So if I lift the patient's leg up and I come here, what I'm going to do is lift up, turn that in, and pull down at the same time. So I'm telling you how it's done without actually doing it, so you kind of see, but this is pulled up. We twist this in, so it's always going to be toe in, because this is always going to be to the outside if they have this issue. And then at the same time, we pull down to open up that joint and cause that twist, or undo the twist, I should say. So in order to perform that, I'm going to come up under the leg. I always kind of bring my body forward a little bit, so I'm not trying to just lift her with my arm. I mean, I could, but I'm going to lift with my body, and then I'm going to take and go here like this. And then as I come down, I hold the upward motion and the twisting motion and pull it down all at the same time. So usually you'll feel it click, and it's not some like crazy amount of force. It's just keeping all those vectors in while you're pulling down. That makes sense? So I'll demonstrate I still use my inside hand here, come here, turn this in, pull up, and then come down.
Okay, it does pop.
Yeah, so like that one popped the very first time I pulled it down, just clicked right into place. I could feel it kind of twist. The other thing that we do is a muscle technique. When you're face up, we have one other adjustment when she's face down. And so we are going to come on the quad here, and we are going to push in with our thumbs. And here, I would actually do this from this side here, but I'm going to demonstrate it there so the camera can see it. So normally I'd be on the other side of I wouldn't reach across the patient like this, but she's going to go ahead and let her leg down. I push in here. This IT band gets very tight on a patient with knee pain. So this typically is tender. Push up. Okay, push up, push up, push up, push up. You let the patient win, but you give a little bit of resistance, right? And this actively releases that. And the further so the further distal you get, the further down the leg you get, the more tender it's going to be in this region versus this region, right? So if we were to see that from this other side, so maybe just be right here. This is how I would do it, typically being on this side of the patient. So let that leg down, push up, okay, push up, push up, push up. And usually we just cycle through it about twice, right? It's tender, huh? Mm-hmm. Like along this outside right here. Mm-hmm. And it's funny because I've done this on multiple patients, like, oh my gosh, it's so tender. And I'm like, look, I'm using like this much pressure, right? I mean, I'm trying to push, but I'm not trying to like just grip through it, right? I had a lady that she couldn't hardly stand it. We actually ended up using like the vibrocussor and just just pushing on it with vibration because she couldn't stand it. It was so tender, right? And that's just unfortunately really common with people with knee issues. Okay, so pause. Now we do an adjustment in the prone position. So once again, looking at this knee, if the tibia was to be out of place, it's typically going to be back on the lateral or outside. And so we do an adjustment where the knee is bent like this. It's the perfect model for this demonstration because the patella tendon's broke, so I can actually bend it. But when you bend this, it'll be technically bent like this because they're laying face down. So this is their femur. And we will come in here and we will do an adjustment pulling this direction, okay? And then we will work the popliteal muscle and tissue right in the joint. So we'll come in here with our thumb and press as we move that leg up and down, okay? Once again, we're gonna bend the patient's leg. You actually come right here with the one hand, and we wanna twist that leg back inward. It's always gonna be toe in, right? You're turning that toe in. So, and the one thing, even the patient we did last night, that one is just a good tug. Like not crazy, just to, get the tension there and give it a good tug. So stay there, that way there's another angle on the video here. But even the patient we did last night, the moment she got up, she goes, oh my gosh, my knee feels so much looser. It already feels better. Like the results are kind of crazy amazing. The only results that we don't see is patients with like crazy amounts of arthritis. If they have phase 4 degeneration and they're on the verge of replacement, this adjustment is probably not going to help that patient. You see I'm turning it this way. Nice tug right there. And Shay probably felt that little release there. So now I come right here, push down for me, Shay. Push your leg, foot down towards the floor. There we go. Yep, and I hold this with my thumb as she pushes down. If I was to say, where am I going? Find the top of the fibula, come up 3/4 and in about an inch right there, okay? So then she just pushes down. And this one should be really firm pressure, right? Yeah. And depending on the patient, they're like, wow, that's really tender. But then the moment you're done, they're like, oh my gosh, moves so much better. So this one here. And for the purpose of demonstrating, I obviously adjusted each knee and then came back and did the muscle work. But typically, I forgot to show this before, but what we typically do is we tell the patient, okay, you're having knee pain, tell me where that is. You say, oh, it's right here. All right, so we're gonna do a test adjustment today. Before we do that, I want you to do a deep squat for me. So patient comes in, does a nice deep squat. If they have knee pain, they probably won't do a squat like that, but they will say, like, I get to, oh, it's right there. I just tell them stop when you have pain. Tell them where that pain is. Oh, it's right here on the inside, like I said, or right here on the outside. How about the other one? Oh, this one's not as bad, but it hurts here. Okay, just remember how that felt. Now we have our patient stand up. Okay, do a little squat for me.
Oh, the table.
Hit the table. Hit the table.
It was good, yeah.
So, and then I usually have the patient walk. Like, I want you to walk 10 steps down the hall and back.